Hi, I wanted to do a quick presentation of spinal cord injury so that we could review some of the important information that I hope you get out of your concept maps that you worked on. So this is when we have an injury to the spinal cord, which causes a disruption in the nervous system function. So this can result in complete or incomplete loss of motor and sensory function. And you can see changes that occur in all of the body's physiological systems. So injuries are described according to where the injury is in the spinal cord. The most common sites of injury are 5th, 6th, and 7th cervical vertebrae, in the 12th, T12, the thoracic, and L1, the first lumbar. Damage can range anywhere from a contusion to complete transection of the spinal cord. This can result in permanent impairment, and typically we're not going to know exactly the level of impairment until some of the edema and swelling has subsided, usually by about 1 week after the injury has occurred. So one of the things that we typically see is, and we've discussed, and I know this can be confusing, so we're going to talk of initially the different types of shock that you can see. Before we even get into that, though, this is one of those injuries that you've got to remember your ABCs. Because before we even worry about spinal shock, neurogenic shock, we really have to assess breathing patterns and auscultate the lungs, because we can see, serious impairment to respiratory status, especially if there's an injury in that C3 to C5, because the cervical spinal cord innervates the diaphragm, so we can end up knocking out respirations. After we've checked for that, we want to check neurologic vital signs and assess sensation and motor functions and assess cardiovascular status. And then after we've made sure that those are stable, we'll move on into, bowel sounds, lower abdomen for bladder distension. And also temperature can be important because our spinal cord injury patients can have problems regulating body temperature. And once we get through the initial life-saving measures, we're going to have a lot of psychosocial impact to our patients also. Our patients that have injuries above T6 will often have problems with hypotension and bradycardia because of that sympathetic nervous system injury. So just kind of keep in mind where that injury's at and what you want to look for. Spinal shock and neurogenic shock can happen together, but they're actually two separate types of shock. And you'll see the different phases here for spinal shock. This is more of a motor type of injury that we see. So it's that motor impairment, the flaccidity, loss of sensation, absent reflexes, and you'll see it's going to happen. Onset can be quickly after the injury. Neurogenic shock is hemodynamic changes that we see, and again, you'll see that it's typically that T5 and above, and so we see that typical kind of hemodynamic shock where we have here low blood pressure, bradycardia, and you'll see we treat here with airway support, vasopressors, and atropine to help with the bradycardia. So hopefully that helps understand those two types of injury that we see. So in that acute phase, you want to make sure that we keep the patient in an extended position with a cervical collar on during any transfer. We want to have good stabilization at the scene. And then it's in, the emergency department that we have that kind of realignment, stabilization. Watch that airway. And you will see sometimes the use of, halo rings, and I've got a picture of it coming up to show you what that looks like. Typically, you'll see that we are going to use high-dose steroids in that first 8 to 24 hours to help with edema. They may have a special type of bed, a kinetic therapy bed, that helps give that continual side-to-side motion. And they're able to kind of have that repositioning while still keeping spinal cord stabilization and realignment. And so you'll see that rotorest bed, it's got like a striker frame with a very firm mattress that we're looking for. You might also see some diuretic use. Mannitol is a diuretic that you'll see that mentioned a lot in our neurologic patients here. It's that osmotic diuretic that we use. It's only used short-term, IV infusion initially. Okay, and then autonomic dysreflexia. Again, this is another life-threatening problem that our patients are at risk for, and you want to always be evaluating in any spinal cord injured patient at T6 or above. This is a medical emergency. They can end up having a stroke because of it. It's usually triggered by some type of a irritant stimuli, such as bowel, bladder, skin, restrictive clothing, pressure areas like you see here. And what you're going to see is, you'll see it right down here: flushed face, high blood pressure, headache, low heart rate, sweating. And we want to pick up on this as quickly as we can and remove the offending cause. And then we'll see the patient kind of return to normal status. So here are the symptoms that you'll see above the level of the injury, and then here are the symptoms below. Typically below, you'll have that pale, cool skin, and we won't see sweating with them. With our, GI, we're always worried that they could end up with like paralytic ileus due to low gastric activity. So always do a good GI assessment. And then know that once we have them stabilized, our patients enter into that rehabilitative stage of spinal cord here at the end. So steroids, possibly osmotic diuretics are used. We talked a little bit about the immobilization that's done. Then there's surgical management where you can actually see hardware placed to keep that spinal cord alignment. In the rehab, we want to make sure that we're helping with deep breathing exercises. They might need chest physiotherapy. We talked about the special beds, anti-embolytic stockings or SCDs, range of motion, turn frequently, keep skin clean and dry. In rehab, they'll do fitting for any special assistive devices such as wheelchair. They'll assess home needs, and it's in a very extensive rehab period patients are in. And then don't forget they'll have some type of bowel bladder training as part of their care as well. Here's that picture of that halo vest device. We want to make sure we've got good skin care to the chest where this belongs. There's typically 4 pins. And we discussed that need to do pin care at least twice a day and assess for infection. Let me know if you have any other questions.